I'm Paul Edney. I'm currently an FCP going into an ACP role. I started off as a physiotherapist for the last 20 years, and then over the last 5 years I've gone into advanced practice. So I've moved across from the general physio role into a first contact practitioner role within primary care, and with that I'm now moving into advanced clinical practice. So I work in primary care where I see patients autonomously without a referral, and we see everything that comes through the door, and if it bends and it hurts, it comes to a MSK practitioner. Mine's been separated into the short arm and the long arm. So we've got the short arm consultation where I'm with a supervision. I've got supervision after every patient. I'm building my competencies and confidence in those scenarios where the more common things are seen more commonly. You get more confidence. I can then move into a long arm supervision. That then takes away from having to see every time, but knowing that if I have got a new case, something that I've not seen before, I can jump straight back into short-arm supervision, knock on my supervisor's door and get a development and support there. I've also got the gift of time at the moment where I do longer appointments which give me time with my patient from a subjective and objective assessment, and then I can move into going through to my supervisor, having a chat and coming back discussing that with my patient. The infrastructure, I think, is really important with supervision, ensuring that you know how your clinician wants to be debriefed on each patient, how comfortable they make you feel. So if it's working well and you're comfortable to go and knock on the door, etc., you've got that supervision, that support right there after each patient, or more when you get more confident further down the line. I mean, I had a case where I had a paediatric child that came in, and I really struggled with the equipment to get the monitor on, and it required one of the other staff, one of the paramedics, to come in and literally show me how to apply the aux monitor just so I could get the right readings. And when you're nervous and it's your first time with a baby, I was panicking like crazy. There are certain scenarios where you go and you debrief, or you're waiting to debrief and you stood outside in a corridor. That can add time pressure. The clinician that is a supervisor may have their own workload, so you're waiting for that workload to go through, that the supervisor to see their patient, and then you can interrupt with your patient. You know, that takes time, and how the clinician wants you to debrief. So there was a scenario where my supervisor was off sick one day, and in the morning before we started we had to make sure we could get a new supervisor, but that meant finding out how that supervisor wanted debriefing, what their case study was like, workload was like for the day, and it just added time pressures to that morning. From the supervisor course, for example, I learned a lot on the course of how to monitor my students and how to develop them, really. So I now use more clinical models, and when we're using a clinical model for my supervision, I let them see how I use those clinical models. So bring them in, let them observe me before then going back and observing them utilising the models. Most importantly though, I think being friendly, being open and allowing the questions to be asked. There's no such thing as a daft question. You need them to be able to ask the question repeatedly, not just once, because we don't learn just once. It's about asking the same question. If they feel they can ask those silly questions multiple times, it gives them a level of confidence to come to you.